What lessons can physicians learn from the COVID-19 crisis? Find out on Medical Economics Pulse.
One of the things about trust in healthcare, which is such an important goal, is that ordinarily healthcare is a high stakes but low frequency interaction, and patients trust it because it's done in a familiar way. Now we're doing care differently, and so we have to earn trust and build trust in ways that are subtle. We have to actually have more interactions, like low stakes, high frequency interactions that actually work out for patients. So there's much more back and forth interaction going on between healthcare organizations and patients right now. And I think that that will help the new models of care be effective in building trust.
There is a serious and underreported challenge resulting from the COVID-19 pandemic. How does the healthcare system treat non-COVID patients? Early data has shown that patients are avoiding necessary care because of fear of the virus. In a recent essay, Dr. Thomas Lee called these patients, many who suffer from chronic conditions, invisible. It's vital, Lee wrote, for a healthcare system to figure out how to manage these patients while still fighting the pandemic. Dr. Lee, who is Chief Medical Officer at Press Ganey, joins me today to discuss ways physicians can ensure all their patients get the care they need. Dr. Thomas Lee, thank you very much for joining us today.
My pleasure.
So I wanted to ask you about what this has been like for you as a physician. Can you talk a little bit about what the experience has been like of being a physician during this pandemic?
Well, it has been, as they say, the best of times and the worst of times. And it's been, in that sense, a great time. I know that we're going to be talking about it, thinking about it, learning about it for the rest of our professional lives. And we have a lot to talk about today.
I wanted to talk with you specifically about treating patients who do not have COVID. You wrote a very interesting article about that in New England Journal of Medicine. And I want to talk about what are the challenges that physicians are experiencing right now when it comes to treating patients who do not have COVID-19.
Yeah. Yeah, thanks so much. I'm glad you were taken with that article. My main job is being chief medical officer for Press Ganey, but I'm part-time, what I've been since 1979, which is a primary care physician with also cardiology expertise. And I follow a few hundred patients as my primary care patients, none of whom actually, one of whom has turned out to have COVID and said no problems with it, but many of whom continue to have issues come up, and meeting their needs and helping them stay calm and trust that things were under control and that they were not being ignored. That's been a challenge for me and every other person in healthcare. I do think that in healthcare, we're pretty good at rising to the occasion and meeting challenges when we recognize them. But having those patients' needs put right in front of us and then responding, that has been real work, and it doesn't just happen by accident.
Can you talk a little bit about some of the concerns that some of the patients have expressed to you, particularly in regards to, patients with chronic conditions, diabetes, heart disease, the things that require constant monitoring that maybe now it's been more difficult for them to get the care that they need. Can you talk a little bit about that?
Sure. And so, we'll put aside, at least for now, the concerns that everyone has that they might have COVID or they might be at risk for COVID. And we'll focus on the concerns that were there before the new year, which is I'm at risk for a heart attack, I'm at risk for stroke, I'm at risk for breast cancer. Those concerns, of course, go on, and sometimes the risks become real. I wrote that article that you alluded to because in one night, well, actually 24 hours, beginning with a night, 3 of my patients had bad things happen, things which led to them being hospitalized. One had a stroke. One had a confusion spell, which is in itself bad enough, but he fell during it and broke his wrist. And then the third one developed an infection around a recently replaced hip joint. All of these patients were elderly men. All of their wives were extremely upset that they could not be with their spouse during really serious episodes of care. I probably spent more time actually talking to the spouses than to my patients. Um, but meeting their needs would have been challenging at any time. Meeting their needs when I couldn't actually go see them myself made it a little harder. But then meeting the needs of them and their families when they were isolated from each other because of COVID made it both difficult but interesting. And learning from the challenge, I think it's been something that we've all been doing healthcare, and I think it's going to make healthcare better in the long run.
Okay, great. In terms of treatment adherence and outcomes, how do you feel that this pandemic is affecting those? Obviously, it's just been a short window of a few months, but just from your experience with your own patients and just from what you're hearing in the medical community about how well patients are adhering to the treatment regimens they were maybe on before the pandemic occurred.
Well, I'm an optimistic guy, and time will tell as we get more data about what's actually happened. But I actually think things may be better. We can't exclude the possibility that things might have improved. And let me give you a couple of reasons why. Uh, First, I am fortunate to be a doctor who is not on his own. I'm in a system. I'm in a good group practice. And that's based in as part of a hospital system. I practice at the Brigham and Women's Hospital. That's part of Partners Healthcare System. And in this crisis, everyone at every level has put aside thinking about what's supported by the fee-for-service reimbursement system, and everyone has been completely focused on meeting the needs of the community and meeting the needs of patients. We have had our best motivations be the only motivations during this period. Not to say we're bad people the rest of the time, but we've been at our best. And everyone has organized in ways to meet patients' needs. We recognized immediately we couldn't be bringing people to the hospital, and they didn't want to come to the hospital for their care. So we, like everyone else, we turned on a dime and we started going to telemedicine. 90% of the visits became telemedicine versus like 3% before, before March 30th. And as we did that, it wasn't just me getting on Zoom with a patient. There were a team of people talking to them beforehand, making sure that they knew the call was coming, going over the medication list to make sure we were all on the same page, making sure that they were going to take their blood pressure so they could tell me the blood pressure when they got on. They got real attention from a team. And then not only did they get real attention from the team leading up to the visit, but after the visit as well. Because I actually think that because we weren't necessarily distracted by the patient right in front of us, we were sort of managing our panels, and we were responding to all the emails, all the phone messages, all the patient portal messages, and doing what was most urgent as opposed to just responding to who was right in front of you. And then the last thing I'll say here is that I and a lot of other physicians who were suddenly doing a whole lot of virtual care, telemedicine, we found that it's different. It's the same in some ways, but it's different in others. And I actually think it's better in some really interesting ways. One is that a 15 or 20-minute visit, ordinarily, if you were my patient, you'd be getting my face-to-face attention for maybe 10, 12 minutes. But when it's a Zoom visit for 15 to 20 minutes, you're getting my attention the entire time. And I am riveted on the screen, and I am taking notes, and there's none of this walking back and forth to the exam room and downtime while you're getting changed or anything like that. It's just you and me. And one little measure I noticed that ordinarily when I would see a patient, when I have a patient session on my Fitbit, it would be about 1,000 steps. In a patient session of virtual medicine, it's about 10 steps. It's like, go get something off my bookshelf and bring it back. So there's a risk of us gaining weight, but the time that I'm not walking around, I'm focusing on patients. So I think that, Press Ganey, we just looked at a whole bunch of patient experience data from telemedicine. The patients feel like they're getting as much attention or more under telemedicine than under conventional care.
Sort of a follow-up I wanted to ask you about conducting a telehealth visit is what advice do you have for physicians who may be less experienced using telehealth in terms of making sure that they're relating with the patient in a way, because a lot of doctors have only done in-person visits, and how do you make sure that you kind of maintain that relationship and ensure that you're communicating in sort of in a warm way?
Yeah. Well, I actually, again, I'm an optimistic guy, but because people are justifiably concerned that technology can be a barrier to humanity, the softer side of medicine, the empathy. Everyone is really aware of it and they're giving it more attention. Whereas if we were face to face, I might well be in the mindset of knowing I'm a good person, not worrying about it, just taking it for granted that empathy and real concern was going to come through. When we're interacting through Zoom or just by telephone, because a lot of the older patients, they're not comfortable with, they don't have laptops and they're not, it's just a telephone visit. Everyone is tuned into the risk that patients won't feel like they're getting cared for. And so everyone is making the effort, and they're making it clear with their initial question that I really want to know, how are things going for you overall? In this particular time, it's actually kind of easy because every phone conversation has to start with, how are you dealing with this, being stuck at home? And everyone's got funny and interesting stories to share. And the patients are expressing their compassion for doctors and in every one of these visits. They're all saying, you and your colleagues are doing such wonderful work. We're so grateful, and so on. And that, of course, raises your morale. You feel, oh, I am part of a great profession and I should be proud and I should actually live up to what my patients are hoping for. So there's some nice and real interactions that are actually almost hardwired into telemedicine visits in this day and age. I also think that most of my colleagues are taking great efforts to really be organized to make sure that the follow-up is happening, because we're so concerned about the system just being so unfamiliar to patients. One of the things about trust in healthcare, which is such an important goal, is that ordinarily healthcare is a high stakes but low frequency interaction, and patients trust it because it's done in a familiar way. Now we're doing care differently, and so we have to earn trust and build trust in ways that are subtle. We have to actually have more interactions, like low stakes, high frequency interactions that actually work out for patients. So there's much more back and forth interaction going on between healthcare organizations and patients right now. And I think that will help the new models of care be effective in building trust.
What do you think we can take? What should doctors and other healthcare providers take from this experience as lessons learned as we move forward? It's easy to say the new normal, but whatever that is, what have we learned in this pandemic that we should take and become standard operating procedure going forward?
Well, I would say three big things, Uber messages. The first is, and I'm starting from the premise that we've actually done pretty well dealing with COVID, considering the challenge the overwhelming challenge, and we're far from done with COVID. I think there are going to be more phases to what we're going to go through. But I think that we should be pretty proud on the healthcare side about how it's gone so far. I think the first big message is when you organize around patients and their needs, good things happen. Things that make patients happy and grateful and make us proud. And as I said, everyone in healthcare that I know completely put aside the financial incentives of how they're getting paid. They did not worry about it. They did what their community needed, and they've done what their patients need. Now there's going to be big financial issues that we're going to struggle with, but that first principle is clearly the right principle. The second principle is segmentation of patients is critical to being able to meet their needs. So virtually every place stumbled onto the same approaches of separating the COVID patients from the non-COVID patients, trying to keep your COVID patients in one emergency department and have a separate area for seeing the patients who probably did not have COVID. Same thing on the ambulatory side. Where I practice, we're doing almost all virtual medicine, but some people need to be seen. And we've got two places that we send them. We send them to the respiratory infection center, which is for the COVID possible patients, and then the other section center, which is for everyone else. We've got hospitals where they've divided their ICUs into COVID and non-COVID. And then there are hospital systems that are making some institutions COVID and some non-COVID. Of course, it's never going to be perfect. And in medicine, we've got a disease where we're at high risk for being paralyzed by exceptions. People go, well, what if someone doesn't actually turns out to have COVID? Yeah, there are going to be people like that. And what if someone doesn't have COVID, goes to the COVID positive place, and then they get infected? Yes, that can happen. That's going to happen, but we shouldn't get paralyzed. So the segmentation of patients into different groups enables you to take better care of them. That's true for COVID. And I would say the big lesson that we should take away from this time is that it's also true for other things as well. That we organizing patients around patients' needs and focusing on them, not as like patients in general, but like patients with breast cancer, patients with stroke, patients with Parkinson's disease. We'll do a better job if we organize around patients and segment them. And then the third part is organizing real teams, teams that are completely focused on that segment. Like the team that takes care of the patients with possible COVID, I'm not on that team. And thank God I'm not on that team, because I would be scared to death all day long. And I'd be thinking about every single thing I was doing as I put on my PPE and took it off. Now, my oldest daughter is on that team at the Brigham. She just finished in the COVID ICU, and she could live a month probably in full PPE, and she would be perfectly fine. She is so comfortable in it. Everything is second nature to her now. Having a team of people who work together with each other, know how to, what each other is going to do, like each other, have formal and informal interactions, is both more satisfying and more effective. So I would say organize around patients, segment patients into groups with similar needs, and organize great teams. Those principles, which, Michael Porter and I have written articles about for like 15 years, I would say what's happened the last 2 months has done more to change healthcare than all those articles that Porter and I wrote over the last decade or so. They were academic in theory before. People just did it on their own, faced with the crisis.
Yeah, it always often takes a crisis as the best opportunity. The one thing in terms of opportunities I wanted to get into is that obviously before the pandemic, there's obviously disparities in outcome along, social determinants of health, along income, race, and all those things. There's been a lot of coverage about how the COVID pandemic has been has affected different communities at different levels. Can you talk a little bit about what healthcare needs to do to make sure we're not leaving behind patients that both with COVID and those without COVID who are sort of getting lost in the cracks right now because of various social determinants?
And that's a hugely important question. And I would say that, I one of the things I do on the side of my Press Ganey job is I lead this publication, NEJM Catalyst. And we had this article from Bergamo in Italy where, one of the first really, really hot spots. And this a group of physicians from Bergamo wrote that very early on that they realized they had to have patient-centered care, but then they realized it was community-centered care. They had to actually take care of their community. The job was nothing less than that. They couldn't do that and be effective with their patients. They had to actually think about the overall ecosystem in which they were working and address their needs. And when you look around the community, you see tremendous variation in how bad things are, based upon social determined issues, based upon air pollution. In Boston, where I am now, in the area of Chelsea, which is a poor area of the city, like a third of the people have tested positive. And when you go into, at Mass General, which is right next to Chelsea, the pediatric ICU has been turned into a COVID ICU. And one of my colleagues was walking around there, and 14 of the 15 names of patients were Hispanic. They were from Chelsea. So this is not something that the fear of COVID is everywhere in rich areas and poor areas, but the impact is highly variable and is driven and it's very much influenced by social determinants. So then what do you do? So like the hospital I work, Brigham Women's Hospital, they just opened 2 miles from me on Blue Hill Avenue in Dorchester, Mattapan, a center for testing anyone. It doesn't matter what your insurance is. It doesn't matter your immigration status. No one is paying, but testing anyone. And they're also giving out food. You have to fill out a questionnaire so you can really make clear that you're qualifying for food and security. But they're doing that, and they're doing it with no revenue at a time that they're losing money hand over fist because no elective surgery and half the ED volume and so on. Why would they do that? Well, they're doing it because we're in healthcare. And the Brigham, I'm proud of the Brigham, but the Brigham is not unusual. People are doing that. Organizations are doing that all over the country. And it's because they realize to be viable in the business of patient care, you've got to be ready to see the community as where you live and work.
That's great. In terms of the patient experience, you spoke earlier about, Press Ganey getting some data about how patients have been satisfied with the care that they've gotten. What I'm wondering about is as we sort of transition into parts of the economy reopening, seeing more patients in person again, how do we make sure that we balance between the sort of this new way we're caring for folks, not new, but this kind of hyper telehealth oriented care to make sure that we're still providing patients with those options while also, going back to seeing patients in the office and those kinds of things. How do we balance to make sure that we're giving patients the care that they need once we sort of blend these things back together?
Yeah. And, and I'd actually make the case that it's not so much balancing as focusing. Focusing on what really matters and, what will build trust on the part of patients that they're getting good care. It's not going to be driven by whether or not they drive to the Brigham and park in our parking lot, which is always fun. can we meet their needs and build their trust as efficiently and well as possible? And a lot of patients and doctors are figuring out that can be done just as well by virtual visits, if not better. And I think that one of the big insights that a number of my colleagues and I are talking about these days is the very idea of what consumerism is changing because of COVID. I mean, you just go back to January, people thought consumerism was, about having a great app that made it really easy for you to book your visit and check your labs and so on. And those are lovely. But I think that what COVID has shown by making people think about what's really important, what COVID has shown is that the new consumerism in the COVID era is about building trust between patients and the system taking care of them. It's also building trust among the workforce and their organizations. There have been layoffs and furloughing and fear that there wasn't enough equipment to protect them. And the organizations can't take trust for granted with their workforce. They have to measure that and build that and earn it too. So I think that it's not like it's a choice between telemedicine and virtual visits. They're all tools in our toolbox that we can use to meet patients' needs. And one of those needs is for peace of mind and trust that we're doing our best for them.
Dr. Thomas Lee, thanks so much for joining us today.
My pleasure.